Thank you, Claire, and good morning, PAPIG, and thanks for having me. It's a real honour to be able to speak to you. It's a little bit of a whistle-stop tour of this. I think, as you can see from the area bold, I'm a very small cog in a piece of group work looking at this area. So penicillin allergy, why is it important, or more importantly, the penicillin allergy label? Why is that important? Well, it's very common. Studies have shown that 10 to 15% of patients have a stated penicillin allergy. However, when these patients are tested, the vast majority, you're talking over 90%, actually do not have an actual penicillin allergy. So it's very much overdiagnosed. And sometimes we think about medicine, quite rightly, as do no harm. It's a very safe approach. So the label sometimes is given out very rapidly to prevent further harm from being administered penicillin. However, the label is not a benign one. It comes with a cost for the patient. So potentially increased morbidity. So the treatment that you receive may not be the first line treatment for your infection. The medications you use may be more expensive instead of using a more standard type of medication. It looks like there's also increased risk of hospital-acquired infections such as MRSA, increased hospital length of stay, and also increased readmission rates. So we think that we're doing good by giving a penicillin allergy label, erring on the side of caution, but actually we may be giving a risk in this with very little benefit to the patient. However, who's going to sort this out? And it's a bit like a needle in the haystack. There are no or very few allergy specialists in the UK. So in Wales, if you're looking at general allergists, you have the immunology department at Cardiff and Vale University Health Board. And if you're looking, and you include me in the pot as someone who dabbles or maybe a bit more than dabbles in drug allergy, you're talking about 4 or 5 people in the whole of Wales who are able to try and evaluate this problem. And that's one adult allergist per a population of 1.3 million. And by adult allergist, I mean an allergist who deals with adults. Not that I don't think there's many children working in this area. So how do we tend to look at the penicillin allergy? How do we traditionally investigate? Well, I suppose we take the clinical history first of all. So that would be a consultation, usually within the outpatient department with a specialist. The specialist will potentially organize blood tests such as specific IgE, that is the antibody that is involved in the immediate allergic reaction to penicillins. And we can test for some of those with blood tests. We can also then move on to skin prick testing. And there are 2 components to that. One where you put a little bit of the medication onto the skin, and you have a small lancet which you prick the medication under the skin, and a slightly more invasive test called intradermal testing, where we actually inject a small amount of the medication to make a little bleb, a little raised area on the skin. It's a slightly more sensitive test, but very much a more specialized test. And after we've gone through those, we should think of all those tests really as a risk stratification. So what we're trying to see is if we give you penicillin in the future, what is the likelihood that you're going to have a nasty reaction? And if you have a negative blood test, negative skin prick test, negative intradermal test, then that would put you into a low risk, but not necessarily a no risk of having a drug provocation test. But as you can see, this is quite an involved process. It requires specialist practical skills and specialist interpretation. So this is not going to be the solution to a widespread problem. As I said previously, in the whole of Wales, there's probably 5 people who would have the skills and the resources to be able to look at this. So what are we going to do? Well, as I've said, 10% of the UK population, being Scottish, I've got to get Scotland in somewhere into a presentation. So this kind of fits quite nicely. So 10% of the population have a stated penicillin allergy. As I said before, 9% of those is actually unsubstantiated, is likely to be incorrect, which is roughly the whole population of Scotland is wandering around with, maybe a little bit more in fact, wandering around with an allergy diagnosis that is actually incorrect. And therefore, we have a major issue that most patients will never undergo evaluation of their allergy, and this will never be removed, because once, as I said at the start, people wish to do no harm. And by doing that, if they see a penicillin allergy label on a patient's document, regardless of the nature of what's next to it, the safe thing for many people is to not give penicillin. So we need to think of a way or a mechanism we can try and address that and remove that label. So there's been recent British guidance published in 2022 from the British Society of Allergy and Clinical Immunologists, recognizing the need to move penicillin allergy delabeling, removing of penicillin allergies out of the specialists and into the generalists. And this also in Scotland, probably the pioneering work really in the UK, bringing all this together in a toolkit. We also, with the group involved in the paddle group at Cardiff and Vale, this document has been through to AWMSG. I think it's awaiting kind of official endorsement now. Basically modeled off these two elements of guidance to produce an all Wales pathway. It's quite a busy slide. I think the key thing to note is the simplicity of the scoring system in the middle. So your risk of having a reaction to penicillin can be predicted using this score called the PenFast score. And what we want to look at is people with a lower score. We would miss out the skin prick testing, blood tests, intradermal testing, and we just give them some penicillin. And as you can see, there's certain criteria where we would be a little bit nervous, so they score highly. So anaphylaxis, of course, is a potential life-threatening allergy. They would get 2 points, and that's a contraindication. And also there are some delayed reactions, which can be very severe. And once again, that would be a contraindication. But also what we know is that in 10 years, if you were to look at a proportion of people with penicillin allergy, a lot of people also will grow out of it. And this is the basis of this. So this tool allows, it's a kind of democratic tool that allows many people to be able to assess the likelihood of having a reaction when administered penicillin. And I think the key thing is this study was looking at secondary care, our work, but I just wanted to touch on probably where we need to really get to if we're going to address this. And so as a secondary care, living in my secondary care physicians, living our ivory towers within the hospitals, we will be able to reach out to our patients and resolve this. But ultimately, we do a very small proportion of the work with NHS, and we need to look at both primary care physicians, but also allied healthcare professionals to support in this, to try and move this forward. Because it's only when we get those groups involved, we really be able to make a dent on this large number. I've just put this study briefly. I know time is short. I won't go into too much detail, but essentially this is a model of, there are studies here which show how primary care practices can actually start delabeling. It's important to say that though the kind of, I suppose, attractive or sexy bit of it, to put that word, is a direct challenge in giving the penicillin, it's important to say from the clinical history and the medical records, probably 60 to 70% of people can have their penicillin allergy removed. So we often think about delabeling as giving someone a penicillin, but actually on the clinical history and the clinical notes, the majority will be able to have their label removed. As I said, this is a community protocol. And I think this is the next stage, what we need to be looking at. I think, of course, I talked a little bit about the cultural barriers to this and to do no harm. So I think this comes with a lot of education and reassurance about doing this type of thing when we've been maybe the last kind of 20 years we've been telling people about just being avid avoiders of penicillin and penicillin allergy, and we're looking for a bit more nuanced approach. What about details? So just to sum up, penicillin allergy is common. I would say it's far too common. Penicillin allergy can be dangerous. I think it's important that we don't minimize that. And I think we have to make sure that we pick it up and we do not administer penicillins in the inappropriate patient. But what we've got to do is to define allergy significantly better to be able to make sure that the patient actually benefits from that definition and is not caused unnecessary harm by a false label. I think going forward, primary care offers the ability to remove more allergies, and I think that hopefully we'll be doing some more work. But there is work going on in this area. And I think the other thing which comes out through all these strands of work is about the educational barriers and also the empowerment of people to take these decisions and initiate these processes.